that Jason is, he can speak. I mean, I know he's muted right now, but he's okay to present.
Yeah, that's Dr. Vasquez. Yes, he has spoken.
Yep, just making sure. Great. Thanks, guys.
Yep.
Hello.
Hello.
We're on the line.
We're giving it another couple minutes and we'll get started shortly.
Thanks, everybody, for joining us. We will get started very shortly.
Hi, everyone. Kim Gaylord, Director of TechRochester. Thank you for joining. We will begin our webinar at approximately 1:03, 1:04, allowing more people to join. So hold tight and we will be right with you. Thank you.
And just so you know, all participants are in listen-only mode. Your mics are muted. So if you're asking if we can hear you, the answer is no. But hang in, we're just about to get going.
Hi, everyone. It is Kim from TechRochester again. It is 1:03, so we will get started to be cognizant of everyone's time. First off, thank you for joining us today for this timely and very important topic related to COVID-19. I want to thank our sponsors for this, which are HIMSS and Strategic Interests, for helping sponsor this webinar today and being a part of TechRochester. As Brett did mention, all of your lines are muted. If you have questions, please use the Q&A or the web chat for those questions. There will be time at the end of both presentations for questions. So we're going to hold them all till the end. And with that, I'd like to turn it over to Armand Morrison. Armand?
Thanks, Kim. I appreciate it. And thanks to all of you joining. And I'd like to introduce Dr. Rowe Vasquez. Dr. Vasquez is a recognized leader in healthcare innovation and delivery. He's a graduate of the University of Buffalo School of Medicine and Biomedical Sciences, as well as Fordham University. And he's been invited to speak at some of the most prestigious universities and conferences in the nation. He's a primary care physician who opened an urban family practice on Buffalo's Lower West Side in 1996, recognizing the need for coordinated person-centered care for Medicaid recipients with multiple chronic medical conditions. He formed the Greater Buffalo United Accountable Healthcare Network, or JUBAN, and the New York State Department of Health approved the designation of JUBAN as a provider-led Medicaid health home in 2012. His most prominent board appointments include Board of Directors of Healthy Link, which is the Western New York HIE, New York State Minority Health Council, and statewide Multicultural Advisory Committee. And today, Dr. Vasquez is going to talk about approaches in the Buffalo area, Western New York, in terms of managing populations at home, both those currently with coronavirus, as well as those that we're trying to protect from contracting this particular virus. So with that, I'll ask Dr. Vasquez to share with us a little bit about his perspective and some of the things that he and his physician colleagues have been doing here in Western New York.
Yeah, thank you for having it. Thank you for having me. I think we put this presentation, but I want to give you a little background. We actually went fully telehealth about 3 weeks ago. So that was 100%. We weren't seeing patients in the office because we knew that for somehow we didn't want to serve as a nevus to kind of really infect people, where the ER and hospitals are often now running into that issue. So the management took place proactively. We looked at our database and searched out the individuals that are at most risk and developed call systems for them. And we have a nurse system, a nurse triage system. So the calls that came in, we were kind of monitoring these individuals for the fevers, cough, shortness of breath, and then determining, who came in for treatment and what kind of follow-up to kind of do. Because, a lot of times we're telling patients stay home, but that's all. Stay home for 14 days. And in our communities, you have, 8 people in that home. You've got, and a grandmother that's 70. So that was not the right message in terms of kind of filtering, basically addressing the issue. We got ahead of tech. We've always been techie. So we had apps, and the apps were downloaded by a lot of the members that we could push information to. So they're getting the right information at the right time in their homes. And that in itself has helped in terms of containing it. But one of the things that we're kind of seeing is, there's really not a lot of primary care that these patients are tied into. And we were looking at a bigger approach. The governor's done a great job, but his approach has been hospitals. And while hospitals are good, most of these individuals or patients are attached to primary care, and a lot of primary care really hadn't really format themselves into the telehealth world. So that's created a problem. So what we're trying to do here is really take a community approach to this and really break people up into different categories. And I put a lot of the slides in there, but what we're looking at is really going after those high-risk, low-income individuals that you want to kind of keep away from this. Otherwise, that curve continues to rise as a result of that. And working together, we have about 220 churches, which have a lot of space. And what we're trying to do is really grab a lot of these individuals. Now, one of the advantages that most of the areas have is they were involved in a district model. And the district model had what are called, lists that you got. And we're trying to use that data as a chase list, because at least you can dissect, zip codes, where they're located close to, what diseases we have, who to call, who to robocall, and at least have something to begin with to kind of tackle that. I find if we take this population and put them in churches and then, provide the supported services there, it would prevent these individuals from getting it. And also having the churches be part of the system, so they're testing individuals, and if they do spike temperatures, where to move them. I think that's the biggest thing that we haven't done as a system, and everybody just be managed at the same time. If we have individuals that have symptoms that come get tested from those families and turn out to be positive and just have fevers, or is why don't we just, basically give them the instructions for home, and having the nurse system call them on a daily, every 2 days, just to make sure people are getting the right information and doing the right things. We also created, we work with a lot of the other groups. So we're trying to develop a system. So if you do come get tested and have shortness of breath and have cough, we have a lot of kids that vape, a lot of people that smoke. Those are patients that we're running into having more of an issue. Is what do you do with these individuals? So we're trying to do is, if we get someone that's positive with these types of symptoms, is really deciding to use the hotels as an isolation. And we also have some sort of respiratory assessment units of some of the teams that we work with, is managing that population there. That way we can treat and do a lot of this stuff through telehealth models and bring in specialists. So if you have a primary care that needs that specialty type of service, we have pulmonologists that can help and basically manage these individuals outside. And if they need to go into the hospital, they can be directly admitted to the ICU, as opposed to clogging up the ER system, which is what's happening now. So these are some of the concepts that we have, but the call systems using this, a lot of practices have shut down because they don't know how to tie into that. And that's how you can bring some of this workforce that we have out there that can really have a benefit. So these are just some of the ideas that I feel that if we start tackling it with these respiratory assessment centers and testing, we can have a better outcome. We're behind the 8 ball because we're not testing. I think instead of waiting for the virus to hit us, we could beat it before it gets here, in terms of really addressing the slow of it by managing some of these individuals in their location as opposed to outside. We decided, to also use other arms. We're telling people to stay home for 2 weeks that may not have food. So some of our entities, our other arms that do a lot of care coordination, we're actually distributing food to individuals and having a touch base to make sure that people are okay. And I think these are the areas that are going to be quite important. On the telehealth side, if patients get put into the hospital and they need, an examination, lung sound, visual, whatever it is, we use Title Care equipment. We've been using that, which is almost a virtual visit. So we can have a navigator, and we have 64 available, that can go out and basically use these equipment with the right protective gear and give that doctor the information they need, as opposed to just, not really evaluating them at the way they should be evaluated. Now, people are going to say, well, we don't have the dollars. Well, we do have the dollars. The dollars are here from the district. The PPS, there's still dollars available at each of the areas. If these entities are able to capture some of those dollars, it's going to be good for the hospital, because there are things that are out there right now in terms of the CARE Act, which is actually going to reimburse a lot of the providers and systems that are doing something within this COVID-19. So it's good for the hospital, good for the providers, and most importantly, good for the community. And those are some of the ideas that I find would be very important now in this time of what I call craziness. But really to technically use the CBOs to provide a lot of that supported structure. So we use something called Holland, which is a ribbon system. That what we do is we aggregate all our claims data, and that information gets transferred down in a encrypted area to this sort of ribbon. And if we give people credentials, it's encrypted, we can have a CBO within that system. So as a family doc, we say this person needs, or the hospital says this person needs whatever it is, we find out the CBO, they get that information, and there's a referral management system to close the loop to make sure that all these services are actually taking place. So I think the best way to treat these pandemic episodes is with tech. I think the tech and really bringing people together so they're not in the same room doing a lot of the different things is really important, and really having the data to chase people, chase the lists that are important of the chronic people that we need to focus on. Because with these types of systems, we put together a 5 to 6 week plan, which we are actually requiring sort of the churches and everyone to do certain things so that we're all on this. But for Buffalo, I see 5 to 6 weeks in terms of getting over this craziness. And most of us, see that may be our best approach to really narrow and bring that curve down, because this is where the problem lies, that we're just waiting for the virus to kind of continue to kill without really addressing the issues which really have to take place in people's homes. I think that's where the bigger fight can be taken to reduce our numbers. So I put it on the last couple of slides. It's more of the flow chart in terms of how we feel. So it's about 140,000 Medicare recipients in every county that we have data for. We can look at the high-risk individuals and then break it up in terms of those lists. Incorporating the churches are important, especially if you got some of the older people in the community. There's a little bit more trust. The Black and Brown community, as you know, is very skeptic of hospitals and the Department of Health, and that can help to really kind of push some of these individuals there, and then help have the churches have some sort of a behavioral arm and also a monitoring system in order to trigger people that may need, sort of testing. And once the testing takes place, we have it in such a way that the nurse center becomes that piece that will monitor, once the tests get done, how the follow-up takes place, and how to really get the primary care doctors that are involved in that process sort of included to do telehealth visits. So, for example, us, on the average, we do about 120 visits within our 2 sites for urban family practice, one of my practice. And what's happened as a result of telehealth, we're doing about 135 to 140 telehealth visits. So volume is up, and we're at least managing people. And I think because we did the proactive effect of calling people and giving them an idea and providing access to phones and really having our people all at the same time helped us. I mean, we work with a health home G-Bond that's ours also. So we were able to kind of allocate people, which we call resources, to different things. Our call system is scheduled now that we have 10 people on each level to make sure that we're getting all those calls managed. And we do about 2,000 calls a month. 2,000 calls a day. So, and we're tracking in terms of, the scorecards to make sure the calls are answered well, they're recorded, and we're trying to make sure that everybody's getting the same level of service. But again, trying the home model, but the telehealth pieces, using, hotels and churches, I think become important because you can really slow that wave outside. So you're triaging to the ER or direct admit from these facilities with providers that are already part of it. And I think that's the best approach for these types of pandemic. So that was all I had for the presentation. If there's any questions, just let me know. And the last slide has more of where the churches are, which are geographically located with regards to the populations. And that's where we feel that instead of creating stuff, we have these massive systems that can really do, that they're there. And with the zip codes, you can pretty much figure out which churches to kind of get people directed to.
Thanks, Dr. Vasquez. Really appreciate it. Brett, would you like to introduce Dave Mintel?
It would be my pleasure to introduce Dave Mintel. So hi, everyone. Thanks for joining us. My name is Brett Kinsler. I'm the partner in charge of clinical services and informatics at Strategic Interests. You know, COVID-19 has created new challenges for healthcare providers and the IT solutions that empower them. And it's only through opportunities like this, sharing our best practices, can we all learn from each other and rapidly respond to our patients' and our customers' needs. I'm absolutely thrilled to have two of Strategic Interests' innovative healthcare clients discussing side by side how they're reducing the surge in their centers and equipping their providers to keep people at home and healthy. So you've just heard from Dr. Vasquez and the amazing things he's doing at a large urban practice in Buffalo area. Now it's my pleasure to introduce Dave Mintel to provide the health system perspective. Dave has 30 years of experience in IT, mostly focused in data warehousing and analytics across all industries, but for the past 10 years, he's exclusively concentrated in healthcare. Dave joined Rochester Regional Health in 2015. He's currently the Vice President of Business Intelligence. I've had the opportunity to work closely with Dave on RRH's COVID-19 remote patient monitoring project and many other projects, and I think you'll get a lot from what Dave is about to tell you. Dave?
Thanks, Brett. I appreciate the introduction. I was just looking at that picture of myself on that screen there and realizing how much has changed over the last 3 weeks. I've grown a full beard since this all started. Not having to go into the office every day gives me the opportunity. I appreciate the opportunity today to spend some time and talk about the solution that RRH has put into practice and a little bit of the tech that Dr. Vasquez has been talking about in his presentation, and certainly appreciated hearing the innovative things that he had to say. So I'm going to spend a few minutes here, just give you a real high level overview of who RRH is. We'll talk about what we saw as the solution or as the problem statement, walk through the solution that we're using currently at RRH, and then a little bit about the process that we use to go through and select and move on with that solution. So the first slide here is our, kind of our stats and figures slide. I won't go through all of it. We have 5 hospitals, 19,000 employees, 8 long-term care facilities, a large lab business with ACM laboratories, and a large home care agency. Our breadth of solutions is typically an advantage for us as a health system. With something like COVID, I think we find that it presents some unique challenges for us because we have patient populations spread out wide in our long-term care facilities and our home health agency workers, and also certainly our hospitals and primary care facilities. The next slide is our brag slide, I like to call it. And again, I want to hit on all of it, but to give people a sense of kind of who we are. Our Rochester General Hospital is listed in Healthgrade's top 1% for the second year in a row. Our Unity Hospital is in the top 5% in the nation. Our magnet designation at 2 of our hospitals, 1 for the 4th redesignation, and the rest of our hospitals are all working towards it. Our Beacon Awards, we're number 1 for the most Beacon Awards in the country. And then our IT Awards, since we're talking about IT, we've obtained HIMSS Stage 7 2 years ago, and we're on Chime's Most Wired list. So kind of on to the topic of the day. This was an interesting meme I came across the other day. Who led the digital transformation at your organization? And I think this is something that I'm guessing that if the lines weren't muted, we'd hear some laughter. Organizations are working quickly to fill the gaps that COVID has exposed in their care models. Many of the items were roadmaps. This is just forcing them to be done much sooner. At Rochester Regional, we found that we had a growing telemed program at Rochester Regional prior to COVID, and we were working on remote monitoring and patient-generated health data projects. But certainly, this incident has certainly caused an acceleration in the way we've been thinking about these. So on the kind of how we've seen COVID hit Rochester pretty quickly here over the last few weeks. I'm a BI guy at heart, so certainly our incident command center has plenty of dashboard utilities to use to understand how COVID is hitting us. And here's one slide that we're using kind of to monitor our total inpatient volume. So over the last 2 weeks, you can see we've gone from 0 inpatients to over 40. And it's been pretty well spread across our 5 facilities. Certainly, our more suburban facilities have had a little less, and certainly our city-based facilities have seen quite a larger impact, as Dr. Vasquez had mentioned in his slides. The next slide talks a little bit about kind of the need for the solution for remote monitoring, and how we came about it, and kind of what we were looking for when we went off to decide what solution we would use. So we knew we needed to monitor and be able to manage 3 cohorts of patients: patients who were presumed positive due to some level of exposure to a person who had tested positive or had been in a high-risk situation, patients who had tested positive but didn't need to be hospitalized and to treat their symptoms, so they were going to be continually monitored at home. And then lastly, employees of the health system who had been exposed and needed to be monitored while in home isolation. On the right side of the slide are the impacts, or kind of the outcomes that we were hoping to achieve. Being able to keep in touch virtually with patients while in high stress times in their lives. Obviously this is something that is going to be one of the most stressful things that a patient could go through. Having to be in home isolation, having nothing else to do but sit around and think about it all day. So we knew that this would likely be a patient satisfier if we had a way to kind of keep in touch with them. We believe that keeping people in their homes and comfortable, giving them a means to communicate with us at the health system, meant that they were much less likely to use our EDs and clog that part of our system even further, unless they were directed to by health professionals. For our employees, it allows us to monitor our employees as they progress through their monitoring and get them back to work as fast as possible, so that they can remain productive for us in the healthcare setting. So a little bit about how the solution works. So the solution we ended up choosing is a solution called Datos, and I'll go into some more details in the future slides, but I wanted to talk a little bit about kind of what the interaction looks like. So on the left-hand side is the interaction from a patient perspective. So the patient is identified as somebody who should be remote monitored. They're sent a text message to their cell phone, and then they're able to download the Datos app for monitoring. Twice a day, they're sent alerts to be able to record their temperature in their home and enter it into the application so that we can see that in a central monitoring location. Also, once a day, they're asked to fill out a current symptoms questionnaire. So that asks them things like cough and chest pain and shortness of breath, days they've been in quarantine, what their isolation status is, and whether or not they've been tested, and if they have a known result. So those are all kind of the inputs to the solution. And on the other side is kind of the care management team side of it. So the care management team is able to connect to an internet-based dashboard. They're able to see all of the information that the patients are entering in. But I think the big key to it is the stratification of the solution. So it allows us to stratify our patients and be able to monitor a large number of patients and see those patients at the top of the board that are the most critical and the ones that we should be providing the most attention to at the moment, and then make sure they're being triaged into the appropriate level of care when that's needed. The next slide kind of goes into and shows some examples of some of the patient side of the application. So on the left-hand side is the daily activity tracker. So this shows them the activities that they're asked to do on a daily basis. The second slide there, or the second image there, is showing them their body temperature recording. So this is where they come in twice a day and enter in their body temperature. If they enter in a temperature above a certain temperature, it gets recorded in red. Otherwise, it gets recorded in green. And then they get reminders throughout the day to do these different activities. So they'll get a reminder in the morning to do their temperature. They'll get a reminder mid-morning to do their survey. And if they choose not to do it at that time, they have the ability to set a reminder to bring it back up to them in a future time. And then also we have there's also a built-in video conferencing function that we've been using that allows us to immediately start up a video chat with our patients and be able to ease their minds or understand better what their symptoms are that they're struggling with at the particular moment. The next slide, and I apologize, this next slide is a little small. It's probably not extremely readable, but it should give you the idea. So a couple screenshots here, the centralized monitoring capabilities. And again, as I mentioned earlier, the real value is the ability to score patients based on their temperature and their symptoms on a daily basis and then stratify them. This allows us to view the sickest patients first, make sure that they're getting the care they need. This also allows a relatively small number of clinical staff to manage a large number of panel or a large panel of patients without sacrificing the level of care. So you can kind of see in that center one on the left-hand side, you can see the kind of the red, the yellows, and the greens. You know, those are the alerts that are popped, you know, as a patient enters something on their app that isn't you know, that's causing concerns to the application, that raises them to the top. And we were able to stratify that by assigning certain weightings to each of the symptoms that a patient has, and be able to, you know, basically customize what it is that we wanted to have be the things that triggered the most high responses within the application. Over the coming weeks, we expect that, obviously, as Dr. Vasquez has said, you know, we expect volumes to rise. You know, we know that this is something that's coming. There is a wave coming, but we feel this solution will help enable us to scale and continue to provide high levels of care to a large number of patients impacted by COVID. So my last slide is a little bit about how we accomplish this. I'm sure that people are curious. So this is a slide that kind of talks about how we went from nothing to something in a matter of about 10 days. Probably a little less than that, but it was about 10 days from the time that we first started looking for and at solutions until the time that we had something up and running inside of our health system. So kind of starting on the left there, it was you know, we've got demos from the solution provider, established our use cases, engaged IT. It was beautiful to have IT involved at the front end of this. You know, so it was great that our business partners brought us in early to make sure that we were well involved in the process and helped them through it. We went through a bunch of IT privacy and security issues, or not issues, but processes to make sure that the solution that we were choosing was going to be secure, was going to meet HIPAA standards, was going to allow us to engage with our patients in a safe way from a data perspective. We certainly started our contracting process early at this time, and then worked through our finalizing kind of our business case development for the solution. We also, so in the next stage, we started engaging our HR and employee health organization. As I mentioned earlier, we have we're using this also for our employees and making sure that we're monitoring and managing our employee population well through this crisis. And we were able to engage our HR and employee health groups early to make sure that any unique issues or things that they wanted us to take into account in the solutioning was taken into account. Nursing is a huge part of this. We have nursing at the front lines for us in the application, and looking through the populations that we're managing and making sure that we're raising to clinicians those patients that are needed to have that care and be that front line to be able to put a clinical look on the application. A physician champion. We had the pleasure of working with a couple of phenomenal physicians in this area, and it was great to get their insight and thoughts, and it was great working with the Datos team and the folks from Strategic Interests in implementing the solution and really customizing to the way our physicians wanted to see the process work for our patient population. So, you know, as you can see, we spent a fair amount of time doing some customizations to the solution, and making sure that it met our needs for both our hospital-based patients, our PCP-based patients, and Epic. So we have Epic as our EHR, and we haven't built tight integration to Epic, but we've built order sets inside of Epic to allow patients to be ordered onto the solution. And then we have reports that are allowed that can be run, and then our Access associates are entering those folks into the Datos platform. And then we had some refinements, and as we've been going, we launched the solution 10 days ago or so, and have been continually adding patients during that time period, and finding that the solutions worked extremely well. I'm actually one of the people who mans some of the technical triage, so technical questions that come in through our help desk, and to date we've yet to have a technical question come in. So I feel like it's been a pretty well run, pretty well implemented solution, and our patients seem to be extremely happy with it. I know when I've gotten feedback from our clinicians who've done video visits with our patients, the patients are very thankful for having the ability to do this, and ability to have that instant access if needed. And yeah, so it's a little bit about how we've been kind of tackling this problem, and being able to try to keep people in their homes, but also keep them monitored, keep us apprised of their situation on a daily basis, and really be able to make sure that we're continuing to provide the right care for them at the time. With that, I think it looks like we're ready for questions and answers.
Yeah, thanks, Dave. That's terrific. Just remind everyone you are still on mute, other than the panelists. So if you do have questions, go ahead and submit those in the Q&A box. Kim, unless you had some other workflow that you'd like them to do, I think that's what we're doing, right? Okay, so let me, Dave, if I can, I'm going to start off by asking you a question. Is ROH doing anything to help maximize clinical staff that may be in slower areas? Maybe they don't have the patient traffic coming in, but they're using this remote monitoring ability to help people work to the top of their license?
I'm not sure I completely get the question, Brett.
So you said that there's nurses monitoring the system. My understanding is that ROH is also using other clinicians that may have been in other roles and are helping to operate this.
Yeah, we actually as a health system, we've kind of adopted a model of trying to make sure that we're leveraging everybody within the health system as best as possible, and knowing that there's going to be areas that have been completely shut down because of the crisis here. And so we have obviously we have physicians who've had to close their practices and aren't able to see patients on a day-to-day basis, and we've been using them to help man the application, and being able to see patients through our video visits, and be able to help monitor the situation, and help continue to move forward with managing the care of our patients.
Great, excellent, thanks. There is a question in the panel or in the Q&A. This one I believe is for you, Dave. Does the app work with a variety of EMRs?
So we've chosen not to tightly integrate it with the EMR at this time, just because of the rapid nature that we brought it up, and quite frankly, we wanted to have that high touch with our patients. So we didn't want to enable an automatic, go from order to implementing. So we wanted to have in between, we wanted to have an access associate reaching out to patients and making sure they were aware that they were going to be sent a text message. So, and make sure that they were aware that why they were going to get this text message, and why they were going to be asked to use this application. So we chose to not have that integration at the moment, because we wanted that high touch. I know through the interactions that we've had with the Datos folks that certainly the ability exists to do that. We've just chosen not to do that, and I'm not aware of why it wouldn't work with just about any EMR that's has standard API type functionality and the ability to reach out to a technology platform like that.
Yeah, so this is a question for Dr. Vasquez. One of the concerns around the country is getting access to medications for COVID positive patients. And a kind of a byproduct of that has to do with patients that are exhibiting symptoms but may not have been tested because of the constraint around testing, and also may need access to those types of medications. What have you found in your proactive approach in your communities in terms of helping people get access to the right medications and tracking all of that using technology?
Yeah, this is a real important question. We ran it. This has been our problem. So we have a lot of people that fall into the category, and we could provide the testing. And a lot of them are our patients. So we have EKGs on them. So we know if they have QT prolongations, and we've used these drugs for a while. The pharmacist will not fill any of these medications unless the patient is COVID positive. And I've had some of them threaten to report us to the Office of Professional Misconduct for prescribing these medications without having a positive test. So that's what you're going to run into. So we have finally got some tests to be able to test the high risk patients, like I told you, and that's been the challenge right now. We talk about waivers, but if it doesn't hurt, I mean, we have these patients. We're not only prescribing, but we're following them up through a nursing model to find out if things work or don't work. But that's a big question, and we're working on the only way around it is doing more of the testing that we're doing right now, in order to make sure people get the right medications.
Right.
Dr. Vasquez, let me ask you, does this change, you spoke about DSRIP, does this change your suggestions for how DSRIP and PPS funding or expansion of funding should occur in the near future?
Yeah, absolutely. I think, these dollars were kind of put to build an infrastructure, not to support a hospital structure. It's how do you really create a medical neighborhood model or community-based model. So, I commend Rochester. I think, the things that they're doing are very good. In terms of the apps, we're doing a lot. We have 3 apps. We have a Urban, GBOT, Jabacal app. About the 12 to 1,300 people are using it, at least from our system. And we're doing push notifications, the temperature and the logs, all that's coming in. We tied into a dashboard that we created in order to, now the dashboard has data coming in from the electronic records, and also it's got a list of individuals that are not part of our system in order to keep that information tracked and also be able to, document the things that we're doing with that individual. Patient portals have been really good too. A good portion of our patients are using portals to kind of create the video visits and drop all this information in there and fill out the surveys. I don't think we're using them enough, and that's actually worked out really well. We use Skype for Business, and I think our Skype for Business, I've got 240 people on it. So at any point, we can move people around, create groups, and really manage a secure. So 128 encrypted secure system. And again, presentation, team meetings, but knowing who's on, who's not, has been real important. When we start to do this on a telehealth model, and Rochester General know, is you want to know who's working, who's not working too, in terms of the teams that you have. So we've actually created reports within the electronic record and in a lot of the PCs that they have, where we run an audit report. We know what they touch, what things were done in that system. And in the dashboard, everybody gets a scorecard to figure out, and these scorecards we'll use in terms of reimbursement models, depending on how people are doing, so that we know who's doing what they're doing. Because that's the biggest problem with telehealth, is you don't know who's doing what they need to be doing. So those are the things that I think are real important. But the telehealth, I mean, it's right in the electronic record for us. So it's just, you push the visit. The nurses call, the patient says everything's okay. They screen the call, and then it gets pushed to the doctor. But by that time, the link is already at the patient's either phone or as a text or email, and they communicate. That information takes place, and that's how we monitor. We know how long they're on those calls, how many of these calls are happening. So, it's just developing models that really make a lot of sense. And we should have been doing this for a while. But I think, like Rochester General said, it's really important. You're being pushed to do what the future looks like. So, while it seems like a really bad thing, this is what the future is for us,
Yeah, absolutely. Thank you. There was a question about the recording of this presentation and the slides, and yes, we will have that up. I believe that'll be up on the TechRochester site, techrochester.org. It might be mirrored on HIMSS. I'm not entirely positive. Kim will address that at the end. So Dave, I have a question for both of you, but I'll ask it first to Dave. you know, we've had a little bit of a luxury in upstate New York or Western New York, I guess, where the growth has been a little bit slower for COVID. So we had a little bit more time to react. Is there anything that you'd recommend as best practices to help our neighbors downstate bring some of these best practices and put them in place?
Wow, that's an interesting question. You know, I think it's, you know, I think what we've done to prepare is try to put models in place that allow us to scale quickly and allow us to manage the patients where they are and not having the patients moving around. The less they're moving around, the better. You know, I think that, you know, from my perspective and the solutions that we've been putting in place, it's, you know, it's really trying to keep the patients where they are, and trying to be able to make sure that we're able to continually monitor them and be able to manage them from a clinical perspective and bring them to the hospitals or urgent centers as need arises, as their symptoms change. I think Dr. Vasquez in his comments, you know, I think he'll probably have a little bit deeper thought process to this. Dr. V?
No, I think you did on. You know, this is a learning process. So yeah, I wouldn't add too much to that.
I mean, I loved your model. I mean, with the way you're using churches and the way you're you know, your thought process there of the community side of it is, you know, is pretty insightful and something that, you know, I know I'm taking a lot away from this presentation. No,
listen, it's like, I think it creates hope. I always tell the teams that you're in my jungle, you know. So we're gonna take this to the streets, because I think it creates a hope model, and it's not letting everything, because the hospitals are a great place, but you're not, these types of wars, germ wars, you can't fight them there, because you know, you're already fighting a germ war every day. This makes it really difficult. But you know, utilizing and streamlining the workflow and how to bring people in and take people out are something that doesn't tie into what we call medical neighborhood models, which are going to be real important. And you know, everybody always talks about primary care, but we never support it the way we should be. And I think like this is a primary care type of model that can really have a big impact in everything we do, you know?
Yeah, definitely agree.
You know,
Dave, yeah, go ahead.
I was just going to say, Dr. Vasquez, you mentioned a concept around heal at home, but I think you took that to the next level, and you mentioned that some of the patients are quarantining in hotel rooms because quarantining at home is either not practical or not safe just because of the volume of people in tight quarters. Can you talk a little bit more about that expanded concept of heal at home?
Yeah, I think, you know, you got to, first of all, you know, there has to be a sort of you've got to know your data. So based on your population, you know who to target. So, you know, we had 5,900 people that were kind of in a situation that we did robocalls with. We have the nurse line, these are the symptoms, a nice description, and people were calling back when they had questions related to that. But then within that, we had about 900 to 1,000 COPD or smokers that are high end. So our nurses call them out to see what symptoms, but as part of the checklist is how many people live with you, you know? And so picking that list and really trying to get them to churches within their zip code that they're comfortable with, to kind of just, because a lot of them can't afford to kind of just find a place to stay, and they're going to need food. So, but then having a protocol within the churches, so if someone does develop these symptoms, what to do. And I think the one thing that we talk about that's not important is we're telling people to stay home, but what do? You know, separate in your sleeping, you know, don't share towels and cups, you know, when you use the bathroom, make sure it's disinfected, you know, clean and disinfect surface items, you know, wash your clothes, open, you know, aerate stuff, and don't break this for 2 weeks, you know, monitor your temperature, you know. And I think, you know, when you start to give them a sort of an approach, then it becomes helpful. If you test positive, you know, isolate and let's do these things at home, but you're okay. But once you develop X, Y, and Z, then we got to go to the next level, which will incorporate, you know, some sort of a hotel. If you're having fevers and cough and you're getting progressively worse with shortness of breath, we have to continue to figure out to do everything we would do in a hospital through telehealth in these locations, because it's much easier to do. And if someone is getting worse, the pulmonologist and the infectious disease already know, let's move them to the ICU. It's sort of that ground approach. We can manage 80% of the headaches that are going through the ER right now.
So, Dr. B, there's a question which I believe is directed to you. Is, do you think telehealth is now the norm, and how, as clinicians, how do doctors feel about it? Do they prefer to see the patient, or are they settling into what the new normal is now?
So I think the new norm is, so we're an accountable care organization too. So we have about 250 primary care physicians within the network. We've been pushing. So as part of our contract in 2019 was to allow the telehealth. And the reason the telehealth is, and it paid the same as a visit. And so a lot of our doctors were moving in this direction. I think we have to do population management in offices. We don't have to bring everybody in all the time. There's things that we can do remotely that don't need to require people to come in all the time. And now there's equipment. So it's not just a televisit. In some cases, you need to get sort of blood pressures and lung sounds and temperatures and see different aspects of that individual. There's technology that we use, Title Care, that allows us to do that. Because, you're here, there's a navigator there with the equipment, and they're basically following the instructions that you're directing. Is, okay, the lung sound, put that right there. Okay, I got the lung sound, heart sounds, I got the bowel sounds, we got the temperature, blood pressure, let me see the ear, okay, let me look at the throat. And you're getting all that information to be able to really manage. So that's a 2-level telehealth visit. I feel that you could do the video if you're looking at meds and different things, but in some of the more chronic diseases, you need a level 2 type. And we haven't gotten as far as doing that, but we're pushing to have a sort of a version 1, version 2 type of model when you're managing this population. And you know what? You do a better job. You don't expose individuals to the wrong things, especially at these times, but there's more of a rap, that the patients appreciate it. We've had people that are COPDers that have been in the hospital on O2, and that's a nightmare for them to come in. You're seeing them there, getting all the information, getting the medications, and they find that to be a better approach for those individuals than having everybody kind of waiting like we normally do, rushing to get everybody through. Is managing the population the way, we were meant to kind of do this now that the technology's here. I mean, you've got Alexa that does so many things now, developing skill sets for them at home to be able to drop in or remind them or doing different things is how to really create this virtual visit managed by doctors. So not everybody has to come in. You're going to need your EKGs and spirometry. Some of them can be done remotely. They don't need to be at the office all the time either. So yes, I feel that this may be the way that physicians can manage more population and primary care can expand its scope.
And this is really a paradigm shift, right? Like I think that clinicians used to look at telehealth visits as something less than an in-person visit, and it's really you're finding the quality doesn't suffer in most cases.
No, and you have time to really look at the data. So I mean, the data drives what you do. So we're seeing, you can run reports and auto reports based on what's coming in and create dashboards similar to what we're seeing. And you begin to get a better picture of who you need to focus on and who's actually pretty good. One thing that doctors don't see when they come into the office is what are called PAMs, patient activated measures, which are health literacy. And not everybody's got to be treated different in terms of 1 through 4 to really get a good outcome. And so, the doctor starts to really have a better management tool, not just be on the treadmill, and trying to get through all these patients, is really having a smart attack of the different individuals, because you'll know if you do something wrong that the outcomes aren't coming out the way you want, especially in transition to care. If you got a lot of people still going in, how do we change that model to chase them if we can't hit quality metrics? So, Rochester's dead on. We have a MedDen mobile unit that with 2 examining rooms that gets delivered in 4 months with a chemistry lab. So it's basically a mobile ER urgent care. And we could do a lot of the retinal exams, everything that's preventive measured because of quality metrics we can do right in the field for those individuals that are going to be really hard to get in and chase them. There's a portion that 5 to 10% that cost us a lot of money, chase them. And that could be done through telehealth models, you know, where you can have remote monitoring there with an RN and the doctor not be there, but basically address the issues that the patient needs and really get the checklists. Once you have them, I always talk about maxi-pack. You do everything you can on that individual. So it's going to be a physical, it's going to be shots, it's going to anything that we have to do during that visit will be done. So in other words, you've already covered, you know, and really address all the issues while you have them.
Dave, something to add?
Yeah, I just wanted to say quickly, you know, I think that, you know, to the question that the person asked too was, you know, people like it or not, you know, I don't know that it's a like or a dislike thing anymore. I mean, I think it almost became a necessity. You know, we're constantly in healthcare being asked to do more with less. You know, we need to churn more revenue with the same volume of people and the same volume, and we need to be able to see more patients, and this is a mechanism that allows us to be able to see more patients in a shorter period of time, provide the right level of care. And I think as we see the demographic change too in our patient populations, we're seeing a population that's more and more wired. They want these kinds of things, and they expect these kinds of things. So I think the physicians that embrace it are gonna see the benefits of it down the road versus those that may be a little more hesitant to jump into it.
Yeah, Dave.
No, and I wanted to say one more thing, but Dave, I agree with you 100%. But what ends up happening is because the model that hospitals can follow is you can take risk on the total population. So now, let's say in Buffalo, we have in Erie County 240,000 lives. You know, if you take a PMPM and then you already allocate your resources for like beds and things like that, it makes the hospital more whole. So you're not caught up in the day-to-day. Now you're doing more of the prevention stuff. Not just waiting for people to come in to get elective procedures where you generate your revenue or putting them in the hospital. You're generating more revenue outside, but the hospitals are a necessity. So how do we sustain the hospitals without just having them kind of fence for themselves, but making them part of a bigger package?
Excellent. Dave, you mentioned, or maybe you didn't mention that Rational Regional at one point was looking at Datos previously for other use cases. So there's a question about whether Datos can be used for small and mid-sized practices, but can you discuss other use cases
Sure.
that you're looking at for remote patient monitoring and what you're familiar with?
Sure. Yeah. No, I think that. So I think to the direct answer to the question, absolutely. I can't imagine why it couldn't be used that way. I mean, as we've brought patients into it, we have the ability to assign patients to specific care teams or specific physicians, so that so we can make it as customized as we want from that perspective. So that so if you had a small or mid-sized practice, I can't imagine why you couldn't stand this up very easily. It's all cloud-based. And then, yeah, to your other question, Brett, yeah, we had been investigating it from, you know, managing chronic diseases, you know, trying to be able to manage our diabetic population was one that we spent some time investigating Datos. And again, it was one of those things that's a roadmapped activity, but wasn't something that had gotten to the top of our list yet. And but that's something that Datos is really well geared towards. So I think there's lots of use cases for it. And I think what COVID's going to end up doing, and I think, you know, both I and Dr. Vasquez talked about earlier, is it's accelerating the way we're going to think about these kinds of technologies and how we're going to implement them and the value that it's really going to bring to our organizations, so that, you know, the next time we have to deal with something like this, we're probably more prepared. And I think we can take it back to our day-to-day lives and be able to get in additional value in how we deal with kind of the normal things that we deal with on a day-by-day, year-by-year basis with our patient populations.
Excellent. All right, I don't see any other questions in the queue. Kim, we'll bounce back over to you for housekeeping.
Yep. So first of all, again, thank you to everyone for attending, and thank you to Dr. V and Dave for sharing this insight of what's happening. I think it's eye-opening to a lot of us, and it's great to see what's going on in our areas. The video is recorded. I will share it with everybody who did attend today via email. And I can include contact information for Brett and Armand if needed as well. So that's all I have. Armand, Brett, do you want to add anything?
I'd just like thank both Dr. Vasquez and Dave Mantell. Really, really appreciate the insights and experiences, and hopefully with that information, we can be better prepared to assist and prevent more rapid spread than otherwise. So thank you both for your participation today.
Yep, I echo Armand's comments. Thank you both to two extremely busy men in this time. Thank you for sharing what's on your mind and what you're doing to help keep the world safe. Appreciate it.
Thanks for having
The
us.
feedback from the feedback from the attendees is thank you guys so much. So enjoy, thanks again, everybody, and we'll see you soon.
Thank you.
Great,
Bye-bye.
thank you.